Okay, let's start out with tendons. And as you may recall, I said tendons have a, I like people have that reaction.
It was tendon?
It was a tendon.
That's what you explained.
So, tendons are constructed kind of analogously to a bicycle cable, where you have a sheath and then the cable itself moves inside the sheath. Well, it's kind of what tendons do, and it's called the tendon sheath and the tendon. And you can have either inflammation of only the tendon or of the tendon and the sheath. Okay? The tendon and the sheath is called tenosynovitis. The tendon alone is tendinitis. It usually results in inflammation from overactivity, from overuse. You can have micro or macro traumas, et cetera, et cetera. Localized, the problem with the tenosynovitis particularly is and the tendinitis actually, the inflammation of either the tendon and or the tendon sheath causes local constriction. So there's difficulty passing through. And that's where a lot of the pain comes from, not only from trauma, but from the constriction of the tendon sheath as it's passing through. And these are 3 examples of tendinitis. There's your lateral epicondylitis, which is also called tennis elbow. Do you have a question, Mark?
Yeah.
Yeah.
Just when it inflames, is there fluid, actual fluid in between the?
Yes, inflammation usually results in what they call edema, the buildup of fluid.
Buildup of fluid?
Yeah.
Oh, okay.
Yeah, that's the primary source of most of these is buildup of fluid causes constriction of the vessels that pass through each other.
Gotcha.
Everybody's here now. That's the case that bothers them in the hallway. So the 3 types of tendinitis, 3 examples I'm going to talk about are the lateral epicondylitis is one of them. That's in the vernacular it's referred to as tennis elbow. Sounds better, but any kind of twisting motion. A lateral epicondylitis, what is that? You have the muscles that flex and the extensors, right? Originate on the lateral condyle. So when you twist, it flexes the muscles that insert there, and one of them particularly that we didn't talk about is extensor carpi radialis brevis. Think about that. Let's parse it out. Extensor carpi, in other words, it extends the wrist. Radialis means it's along the radius, and brevis, so it's short. Okay? So what does it do? It goes from the lateral epicondyle to the radius, and it's part of the recovery from twisting motion. Okay, what do you do when you play tennis? You do this, right? And you have a lot of twisting of your forearm. Other things are using a screwdriver or any kind of twisting motion that you perform at work repeatedly. Okay, or baseball pitchers. What do? They put a spin on the ball and they twist their lower arm, and so they get a tennis elbow as well. Bicipital tendinitis, it's the long head of the biceps tendon from flexion. And it's anything that's chronic forceful contraction. So if I'm doing a task that causes me to lift repeatedly while I'm performing the task, what might that be? Lifting boxes. Lifting boxes and putting them on a conveyor at Amazon. Okay? That could be a possible type of tendinitis. And then rotator cuff. And notice I'm moving up from the lateral epicondyle to bicipital tendinitis all the way up to rotator cuff. And the rotator cuff is primarily the deltoid. However, think of all of the tendons and ligaments that are required to hold to hold your the proximal head of your humerus, came apart again, into the the acromial process, the coracoid process, and the lumped out there for a minute. Never mind.
Glenoid cavity.
Sorry.
Glenoid cavity.
Yeah, thank you. Thank you. The glenoid cavity there that have to hold the head in place.
Just remember, my cousin Glenn had to go to the dentist to get his cavity filled.
Oh, you never remember that as a mnemonic.
Oh.
God, you gotta come up with better mnemonics than that. I mean, use one of the obscene ones online. Come on. You won't forget those.
Yeah, it's nice.
Anyway, sorry, I couldn't resist. Where was I now? Okay, rotator cuff. So this is of the tendons from adducting. In other words, you working with your arms over your head. Well, people that work electrician, it's a good example. And by the way, there are other things than rotator cuff tendonitis that people who do overhead work. We'll be seeing that there's that's has a number of different problems associated with it. But also think of barbers and hairdressers. What do they do all day? Like this, right? I mean, they actually get a lot of problems with that. These are some examples of the tendon only being inflamed. Now, the tenosynovitis, these are a couple of examples. And some of these I just picked them because I love the names. Stenosing tenosynovitis crepitans. Okay, crepitans, when something crepitates, that's actually, believe it or not, an English word. Right? To crepitate. Anybody know what it means? Crepitate means crackles. Okay, crackles or pops when it moves. So it's kind of a crackling. Yeah, I know it sounds like a cereal, doesn't it?
So like when you crackle the knuckle?
But the name just didn't make it. You know, crepitating Krispies, you know, something like that. Sounds like something you'd serve on Halloween. But anyway, sorry, was there a question? I sort of got off on a tangent there.
Well, it was just ratcheting, just back on the other side. So I've done a lot of ratcheting. I've got pain back here. Is that?
Well, no, it's actually during motion, it might pop a little bit.
Okay.
Sometimes audibly, not necessarily, but you can feel a kind of a crackling, or so I understand. I've never had this, but so I understand when I read about it. You can feel kind of a crackling feeling or popping feeling while you're moving the limb.
Okay.
In the tendon and the tendon sheath, and that's what crepitans is. This one, the one stenosing tenosynovitis crepitans is trigger finger. Okay, so they used to, in something like pneumatic hammers, other devices that they use on the lines in plants, they used to have a single actuated trigger. Has anybody seen what they replaced that with most of the time now? Is a full handle. You just squeeze the handle. It distributes the force across all four fingers, and you're much less likely to experience an injury. So, but this is the flexor tendons, and it causes a swelling of the tendon sheath. That's all it is from that concentration of force on the trigger. The Quervains is a repetitive, forceful exertion of the thumbs. And the name of that finger is abductor pollicis longus. Remember what I said the thumb is? Pollex? So it's the long abductor of the pollex of your thumb. So that's what you do when you do this with your thumb. Okay? That's the abductor. And the extensor of the pollicis is to extend the last digit. So those are from forceful exertions, but mostly from recovery. Okay, so what are some of the things that you can develop from de Quervains? Well,
Skiers maybe get
Text-
those because they have to hold the.
Not so much, because that's not repetitive. But
Static.
how many people text like this?
Mm.
You could develop it from something like that, or anything that you have to press with your thumbs.
Or sudden like helicopter pilots or fighter jets, they maybe have to.
Xbox.
It depends on how often you do it. Because most of the time, you're not doing it constantly. We're talking about high
Oh, going up
repetition.
and down, keep going up
Yeah,
and
yeah,
down.
you have to do it high repetition.
Oh,
before you
okay.
can-
But playing video games, so then you have to use.
Video
the
games
mouse.
is a good example, yeah.
Um,
And then the byproduct, and also, I just wanted to mention, ganglionic cysts are a byproduct.
Hey, I had that.
I'm sorry?
I've had that.
A ganglionic cyst?
There you go.
Okay. And was it a nodule under the skin? Right there in your wrist, exactly. That's where it very commonly is. As it appears as a nodule under the skin fluid, synovial fluid. Where synovial fluid is what's in the, it's sort of the lubricant in the tendon and tendon sheath arrangement, the tendon synovial sheath.
How does
Baker's.
this happen?
Hmm?
How does this happen?
Well, this is a byproduct of any of the tendinopathitis.
Oh,
So, I've heard of Baker's knee before, or something like that.
Baker's knee.
Yeah, I know there was some fluid,
Well, the prepatellar, the
or yeah, it was on
prepatellar
the forward
bursa.
side.
It's usually carpet layers that
Yeah.
experience a problem with it. I don't know.
I'll have to look up what it, I
Yeah,
thought it
yeah.
was called
That's
Baker's.
interesting. That one I haven't heard before. But yeah, if you can find it, let me know.
Google.
Okay. So how do you? This is a test for declarvans. Right? It's to hold your hand like this, and then extend it as far as you can. If all you feel is stretch, which is painful, but it's not. But if all you feel is a stretch, it's okay. But if you have pain along the radial styloid here that is beyond just the pain that you experience by stretching it, that's a possible positive declarvans. Okay, these are just some really quick tests for some of these conditions. Yeah.
Disease makes it sound like, I mean, obviously it's the right word, but is it the right word? 'Cause
Probably disease. Yeah, because it makes it sound infectious. I know. I know. And it's probably more of a no. Disease is more of a word that's used in a sloppy manner. I think is probably a better way to put it. Because this is something that you contract from repetitive motion. It's probably more likely to be actually a disorder than a disease.
And then the secondary follow-up, if it's a disorder, can it either be acute or
Chronic.
chronic? Like, let's say you play video games for 5 hours and
Mhm.
afterwards, that's going to go away and
Well, yeah. Well, see, that's transient.
transient.
Because if you do it 5 hours every day for the next year, then you might injure yourself. Then it becomes a chronic disorder. Yeah. And this is just for your benefit. Again, don't memorize this. This is just for your benefit. It is a list of some injuries, which I picked out a few, and the features and the factors that are that may result in that outcome. Muscles, and just when we move on to muscles then, there's a couple of different stages. Myalgia, anything with the suffix algia is pain. Neuralgia is a headache, right? Myalgia is pain in your muscle. Okay, remember the mya is the prefix for muscle, and algia is the suffix for pain. And then it can progress to actual inflammation if you have this disruption at the microtissue level, which is myositis. What you were talking about, James, just as an example, you could get myalgia just from doing it for a while. You continue it, you might get myositis, but if you give yourself a rest, you get over it. If you don't give yourself sufficient rest, you won't get over this, and it can develop into a muscular dysfunction and actually damage the muscle. can cause permanent inflammation. Well, not permanent inflammation, but it gives you inflammation which you don't allow to recover, and that disrupts the tissue at the microscopic level.
Could that be a genetic condition as well?
I don't think so. Why do you
Okay.
ask?
Just, I had a friend, she had since very young age, had
Fibromyalgia?
yes.
Fibromyalgia is a slightly different condition, but
Oh,
it
okay.
involves muscle pain, and it's a painful condition that affects all of your connective tissues. That's why it's fibro. And why they stuck the my in there, I'm not sure, because muscle is a connective tissue too.
Okay.
But it's a painful condition of all the connective tissues. From what I know, nobody really knows what causes it, but it can be quite debilitating. And I don't know I don't know that anyone knows if it's genetic
Okay.
or not. The bottom line, as much as I dislike that phrase, is that if you injure your muscle enough, you can't generate enough force. It causes weakness eventually in the muscle with enough micro trauma and macro trauma inflicted on it. Some examples: tension neck. That's from punching all day. What do we do when we punch all day? Computer. Those are the main culprits in causing us to punch all day. And that primarily affects trapezius, but then some of the other muscles as well. Okay, capitis muscles. The other one is writer's cramp. And the only reason I threw in writer's cramp is we don't have too much of a problem with writer's cramp anymore because we all type everything. I don't have a problem with that. Now, when I was in college, whenever I had, maybe I can do writer's cramp, but whenever I took exams, I got writer's cramp, okay? But what I loved about it is I ran across this term for it, focal dystonia. If you ever want to impress anybody, don't tell me you have writer's cramp. Say, I've got this awful case of focal dystonia. And it was particularly common, and that actually is a 19th century term, focal dystonia. And it was particularly common because there was a profession in Victorian England, I think it was at the same time in this country, called scriveners. And actually even Melville wrote a short story about scriveners. It's called Bartleby the Scrivener. Never mind. I digress again. But anyway, the scriveners, what they did, they were essentially human Xerox machines. When they needed copies of documents in businesses, law firms, scriveners were the ones that sat there and they copied it, and they copied another copy of it, and they made another copy of it, however many they needed, and they wrote it out. So that's when that term came up, and when it was actually a problem. Now it isn't. Another summary for your consumption. Now, in talking about nerves, okay? In talking about nerves, what we have to consider is the innervation pattern, the cutaneous innervation pattern of nerves. Okay? And this is a map. This is a posterior, right arm, the anterior right arm. Color-coded cutaneous innervation map of the nerves, of the muscle, of the nerves that pass through the subclavian or the brachial plexus. Okay? What I would like you to be aware of, there's three primary nerves for the upper extremity: radial nerve, ulnar nerve, and the median nerve. Here. It's radial, ulnar. Those are easy to remember. 2 bones of the forearm. Those are nerves that are associated with the 2 bones of the forearm. Radial, ulnar, and the median. Okay, think statistics, not medial. Median, the median nerves. Those 3. Because These are, and also they innervate in a very unpredictable fashion in some ways. But look at the yellow here. Okay. The yellow is the median nerve. The blue, and that's what you'd expect, is the ulnar nerve. Okay, it's the last digit and half of the fourth digit. Okay, and along the side of the medial side of the hand. And then the radial nerve is sort of the back of your hand, whereas the median nerve is the front. Okay. And also different other parts of the forearm and the upper arm are innervated, but what I'm interested in is the hands. And I have a reason for that. Because, oh, and this is a depiction of just the median nerve, okay? How it passes through the subclavian plexus area here. And there's underneath, in your shoulder here, there's a lot of, all the blood vessels, all the nerves that pass from the nerve roots in your neck. Everything that goes to the arm goes through a bunch of let's see, a cluster right there. That's a plexus. I remember sitting in an anatomy class one time, and the instructor was telling us about the brachial plexus here. And he said, one thing that annoys me the most about movies is that where's the guy get shot? Right here. And they always get shot here, and they jump up and run away. He says, if you get shot there, you're not going to get up because there's so many blood vessels and nerves right there. Minimally, you'll lose use of that arm if you get shot through there. Okay, minimally. But then there's a whole bunch of other things that will probably cause you to bleed to death very, very quickly if you get injured right there. So that kind of stuck in my mind. He said that was one of the biggest mistakes in these seasoned movies. And if you ever saw, never mind. I digress again.
Oh,
Interesting. What is it? Come on. Come on.
I'll tell you during the break. This shows the path, the median nerve, and if you'll notice, it goes through the carpal tunnel, right? This is a simpler version of it in cross section. If we cut through the hand, that carpal tunnel there, the median nerve passes through the carpal tunnel. This is the carpal bones. These are the other tendons and blood vessels. That's the median nerve. The radial nerve and the ulnar nerve do not pass through the carpal tunnel. That's why carpal tunnel syndrome is so specific, because you can identify it depending on where the tingling happens. If the tingling doesn't happen in these first three digits at the front part of the hand, it's not carpal tunnel syndrome. That's one of the ways they diagnose it. Because if you have tingling in these, on your little finger, then it's the ulnar nerve, and it has nothing to do with carpal tunnel because that nerve doesn't pass through the carpal tunnel. Okay. So the flexor retinaculum is remember, it's the ligament that covers the contents of the carpal tunnel and keeps them enclosed. Okay. That's why if you do something that is extreme deviations of the wrist, it compresses the contents of the carpal tunnel, that causes inflammation, and it causes edema, it causes swelling because of buildup of fluid, byproduct of inflammation, inside, underneath the flexor retinaculum, inside this carpal tunnel area, and it compresses everything else. It compresses the median nerve, it compresses the blood vessels, it compresses the tendons, and it causes, lots of times, if it's advanced far enough, it can cause loss of sensation and use of these three fingers at least. And I don't know about you, but I'd rather lose these two fingers than these three, because we use those a lot more than we use that. So that's why carpal tunnel syndrome can be so debilitating, is because it causes the loss of the use of fingers that are very essential for daily activities. Okay. Okay. Before I talk, I don't know why I tossed these in before I talk about carpal tunnel, because I kind of split it up. But just so you know, things can be entrapped anywhere, okay? You can have entrapment of nerves anywhere. If you entrap the nerve at the elbow, the median nerve, if you go back here and look at the median nerve, it passes through the elbow here, okay? And it can become entrapped. Anterior interosseous syndrome. It causes, is from entrapment at the elbow. And then, primary caries at the elbow, and at the forearm is anterior interosseous syndrome, sorry. So it can become entrapped anywhere along its length, depending on the activities. And that isn't necessarily entrapment of the nerve, because anything that's compression on the nerve is referred to as entrapment. Okay? And it's not necessarily entrapment between two anatomical parts, like the carpal tunnel syndrome is entrapment between the flexor retinaculum and the tendons and the carpal bones. But it can also become entrapped between an external object. So if I sit all day with my elbows like this, it can cause entrapment of the ulnar nerve. Okay? That's what happens when you hit your elbow, your funny bone. Okay? You're temporarily entrapping the ulnar nerve with an external object, and that's what causes the tingling down your arm. Okay? That's the pattern of cutaneous innervation. On a test for carpal tunnel syndrome, this is Phelan's test. And nobody can, well, unless you're a contortionist, you can't do it like the illustration, but this is a way to, if you feel, once again, everybody feels some pain when you do these tests. And if you feel anything other than stretching, that could be a sign, positive for CTS. And another one, if you hold it for 1 minute and you get pain. So I'm not going to stand up here for 1 minute and do it, but if you hold it for 1 minute, then if you could get, it could indicate that. Tennell's test is another one. You tap the median nerve right there, and you get tingling in the. Yeah, well, you have to tap it precisely on the median nerve, but don't. Just be aware of Tennell's test. They're considered, for you guys in EPI, they're considered first stage screening tests. Right? When you're going through multiple stage screening tests, that's an easy first stage test to test, and then you do something more invasive later. These show you the range of what's called sensitivity and specificity. Sensitivity is the ability to detect positive when it truly is positive. Specificity is the ability to detect negative when it truly is negative. In other words, identifying true negatives and identifying true positives. Identifying true positives has quite the range. Identifying true negatives has a somewhat tighter range. It's better at that. This is an illustration of the ulnar nerve as it passes actually posteriorly to the medial epicondyle, and then down the medial side of your arm along the ulna. And this is the cutaneous innervation pattern of the hand. Or these two digits primarily. There are a couple of problems that you can that can result in entrapment of the ulnar nerve. First was Guillain canal, wrist flexion and extension, and hammering. Okay,
Eddie, just mute it.
and that can cause what's called Guillain canal syndrome. Might want to step back, you can't stop it. Entrapment of the ulnar nerve on the medial side of the hand, right here. And then the other one is the cubital tunnel. And that's because the old measurement of the cubit is the length of your forearm, right? And so it's called a cubital tunnel because it's entrapment between these two muscles here of the flexor carpi, in other words, from flexing the wrist. And that you can develop from putting your hands on a hard surface. That's why it's good to have padding. And that's another reason why it's a good idea to have wrist pads. The problem with wrist pads is what most people do when they're using a wrist pad when they're typing. Cram your hands down like that and you try this. Worst thing you could possibly do, therefore rest it. When you're done, you rest it there. But when you're typing, you should have your wrists straight because you want that neutral position. And so don't cram your wrist down on your wrist pads when you're typing. Only do it as a resting position. So these are important only because it shows that you, even though we have entrapment, it's not entrapment necessarily in the carpal tunnel. It can occur anywhere in the upper extremity, or anywhere in the body, actually. And then there also is a radial tunnel, and forearm rotation is another thing. Not only is it lateral epicondylitis, but also it can result in radial tunnel syndrome. And the radial tunnel from that constant twisting motion. And this is just a demonstration. I couldn't find a nice innervation pattern for the radius other than this. This isn't quite as nice an illustration, but this shows a radial innervation for the hand.
Do you not have to know these diagrams, by the way?
You're
These
your
wonderful,
diagrams.
colorful diagrams.
I'm not going to ask you to describe, Guillain Canal syndrome. However, I might ask you to tell me about entrapment syndromes and give me an example or two.
How about labeling? Will there be labeling?
Of these, probably not.
No.
Probably not. Okay, and then, oh, this is a nice illustration. I should have put this one front further of the brachial plexus, because you can see here are the cervical nerve roots, and they pass through this highly, this really busy area under the clavicle, because in this illustration, the clavicle's cut away, and then you can see the nerves. The nerves are yellow, arteries are red, and veins are blue. You can see everything that passes through there, and it provides blood flow and innervation for the entire arm as it passes through that subclavian plexus there. So if you have entrapment at the plexus, that's referred to as thoracic outlet, as the thoracic outlet, and it's thoracic outlet syndrome. And again, thoracic outlet syndrome, it can cause problems with the use of the entire arm, and that can result with overhead work. People who do electrical work, who install ceilings, who plaster ceilings, any kind of work like that that people have to keep their hands over their head while they're working, can result in thoracic outlet syndrome.
Maybe there's some people that do signage works and certain...
Depends on the position, but yeah, if they're standing like this, doing their tasks during a greater part of the day, absolutely. And this is clavicle in the first rib, and scalenus muscles in the back of the neck. But that's less important, other than just the general idea of the entrapment and thoracic outlet. This is a whole bunch of nerve entrapment conditions. Vascular results from ischemia from inflammation. It reduces blood flow. That reduced blood flow causes tingling, and sometimes you can lose fighting control just because of lack of blood flow. Not necessarily, although it's usually accompanied by nerve compression as well, nerve entrapment and compression. Vibration and cold, and direct pressure are the three risk factors. Hand-arm vibration, that's also called white finger. Okay? And there's a congenital condition called Raynaud's, which many people suffer, which doesn't come from occupational sources. When it's occupational, it's usually called white finger. That's vibration, and working in cold, that sort of thing. Hypothenar hammer syndrome. Okay, hypothenar means it's underneath the thumb, so it's this part of your hand, and it's so it's just a small group of muscles. Remember, I said there are very few muscles in your hands, but you do have a few, and it's a small group of muscles that are underneath, at this part of your palm that can be affected, and that's again hammering. And then thoracic outlet is often considered neurovascular, as is carpal tunnel, because when you compress the contents at the brachial plexus or the contents in the carpal tunnel, you're not targeting just the nerve. You're affecting both the nerve and the blood vessels that pass through there. So they are more accurately referred to as neurovascular, since it can affect both, and often does. Bursitis. So these are synovial sacs that are, we have bursa in our shoulders, we have bursa behind the knee, and one of them, there's prepatellar bursitis, and one behind the knee, carpet layers, common source of prepatellar bursitis. Subacromial or subdeltoid bursitis is what we experience when it's in our shoulders, and again, that's overhead work. Okay? There's a lot of different things: rotator cuff, thoracic outlet syndrome, subacromial bursitis. All of those things we can experience from doing overhead work. Okay? All or some of them. Bone cartilage, unless you break a bone, is not commonly occupational. It's acute bone breaks, but rheumatoid arthritis is a generalized inflammatory process. Osteoarthritis is usually age-related, and that's associated with joints. But those aren't usually occupational. Rheumatoid arthritis is probably genetic, probably. Osteoarthritis is usually age and use related, but they're commonly not occupational. This, again, it's not to be memorized, but I hope that you will use this as a kind of a glossary, because it's interesting. It has some common activities over here. One of them, take a look at this, musicians. First tendonitis, carpal tunnel, epicondylized thoracic outlet, depending on what you do. What can be more repetitive than playing a musical instrument? Guitar, piano, drums. They're very repetitive activities, and if you do it occupationally, you're very likely to contract a lot of these conditions. Did you have a question?
Drums be less repetition and more vibration then?
Possibly, yeah, that's a good point.
Violin.
Violin also, because you have the fingering, any stringed instrument. But you also have that with wind instruments, they have a lot of fingering. So there's a lot of different repetitive activities involved with playing musical instruments of various kinds. And the rest of these aren't so much things that you'd be surprised about, but it's an interesting list. And I encourage you to take a look at it. You may find it useful in illustrating an answer to a question. I'm going to ask you, what can musicians experience? What's the problem with it? However, if I ask you a question about repetition and give me some examples, this is a good place to look. That's why I put it there.
It looks like pretty much everyday chores. I see a lot of everyday chores on the list. Cooking,
those things we do occupationally, unless we're sitting very quietly when we do it. I can't think of anything that allows you to sit quietly while you're doing it.
So also working on a computer, people who are there.
We will be talking about that, yes. Computers are a source of problems. So those are the upper extremities. We have this vast array of anatomical systems, or some combination of them, that can be affected by doing common activities. The back is probably our single weakest point. because that's where we experience degeneration on a species-wide basis. And there's probably no place in the world that people don't experience back pain of some kind. And that's because of our adaptation to bipedal locomotion. Okay? It's biomechanically very, very hard on the lower back to walk upright habitually. I'm not making any suggestions, but I'm just saying that that's a byproduct of the way we walk around. All these things are things that can happen to you. We can strain muscles. It's extremely painful, but you can recover from that. Even a torn muscle, as painful as that is, it is something that you can recover from. You can sprain ligaments. One of the things that's most difficult is degeneration of discs. Discs can either compress or they can herniate. Now Sam here is lucky enough to have an illustration of a herniated disc on the side here, which you guys probably noticed. I think somebody pointed this out. That little red spot right there. Because a disc, if you compress it enough, just like a jelly donut, eventually the jelly's going to squirt out. Okay? Now the annulus fibrosus is tough enough that instead of completely dehydrating, what it'll do is it'll just cause a bulge in the disc. What does that bulge in the disc do? Not only does it decrease the ability of the intervertebral disc to cushion between the vertebra, but look at it right there. What does it do? It compresses the nerve root. It causes pain through the compression of the nerve root. So that is something that is very, very difficult to treat, and sometimes they immobilize. What the physician does is they go in there and they essentially clamp the vertebra together. Now you reduce a lot of mobility, but it keeps it from compressing the nerve root. Did you have a question, Lisa?
Yeah, I was wondering, what's the name of that problem or issue?
Disc herniation, or is that what you're talking about?
Yeah, with the bulge?
Yeah, the bulge, disc herniation, yep. And dehydration, it can degenerate so that it just causes less cushioning. We experience dehydration of the disc normally over the course of the day. We lose a couple of millimeters from when you wake up in the morning until you go to bed at night. You lose a couple of millimeters because it's been compressed all day. When you're lying down, it has a chance to rehydrate and expand again. And then you can have fractures and breaks of the bone, and the nerves are all has to do with compression of the nerve root. It's either from degeneration of the disc or it's from stenosis. In other words, narrowing of the openings of the spinal canal, of the transverse canals through which the nerve roots pass, and degeneration or narrowing of those causes a compression of the nerve root as well. And something that usually causes is not necessarily, it can be pain at the back, but you can also feel pain in your big toe, for instance, and that's related to compression of the nerve root because you usually feel it downstream from the nerve root. I'm almost done, so I think I'll just go ahead and press forward, and then we can finish up. Sciatica is a nerve compression problem that people experience. It radiates down through the sciatic nerve, which passes underneath, right here, which passes underneath the ischium. Okay? I read something interesting a number of years ago that an aggravator for sciatica, or even a potential cause for sciatica, is carrying a wallet that's too thick. So if you if you keep every card that you ever collected and stuff it in your wallet so it's about that thick, carry it in your back pocket, it's likely to cause aggravation of the sciatic nerve because your wallet hits right where the sciatic nerve passes into your leg.
The lever is a Seinfeld episode. I'm pretty
Yeah.
Are you serious?
Yeah.
I never saw that. I'll have to find it now. Okay,
Yeah,
thanks.
it's-
I'll show it. That's a lot easier than talking about it. I really will enjoy that.
George had a thick wallet.
Yeah, that's it.
Okay. So anyway, that's one. Yeah.
I was wondering for the exam that will be coming up, would you be asking us what type of injury would be connected to what muscles or ligaments or tendons?
What I'd probably ask you to do is, like, I'd pick a type, like neurovascular disorders, and I'd say, tell me about neurovascular disorders and give me an example. Tendon and synovial sheath disorders. Tell me about them and give me an example or two.
Oh, good.
And the better you describe it, the better the answer.
Sounds
Does that help?
Yes.
So if you can name one of each of those and describe what it is you're doing, okay?
I tried to target two, just to
Okay.
play it safe.
Oh, so we have options to choose from.
You have options. I'm not going to ask you to. Okay, tell me what the symptoms are and causes for Guillain-Barré syndrome. I'm not going to ask you that. But I will ask you about nerve disorders.
Yeah.
I can tell you what
Well, still, I was just wondering like how to
Okay.
focus.
Okay, the lower back. A lot of. I wrote a lot there. That's for your consumption later. But the outcome of this is two things. First of all, this figure right here, 12 to 15%. This is from. Let's see. Do I have the? I don't have the name. I probably have it on the first page. I don't remember. But there was a series of studies by authors Bigos and Batty. I think it's a double T, I-E. And I believe they were at Harvard Medical Center in Seattle, I think. And one of the things that they concluded, 2 points. One of the things that they concluded is that only about up to 15% have an identifiable, of low back pain have an identifiable cause, where you can take an MRI or an X-ray or something like that, and actually identify what's causing the pain. You've got stenosis, you've got a break, you've got a strain, you've got nerve compression, you've got disc degeneration. Those are that's what's referred to as a pathoanatomic basis. In other words, you can look at it and say what causes it. But think about that, 85% they can't. And everybody's first thought is malingerers, right? And I'm sure that there's a certain number who are. However, I was on the staff of a research project where that's exactly what they wanted to try to find out, is what help people who have, and that's called non-specific idiopathic low back pain. In other words, they have no idea what's causing it, they can't do anything for you, and the people that came in, all the ones that I interviewed, because I interviewed a bunch of them, all the ones that I interviewed, if any of them were malingerers, they were the best actors in the world, because these people had lost jobs, they lost houses, they were divorced. I mean, it caused incredible repercussions in their lives. Number one, because the pain was so bad, and number two, because nobody could say what it was caused by. But it ruined their lives. And so I kind of doubt, I'm sure there's always malingerers, okay? That's a steady state undercurrent. But these people that I talked to, I'm certain that none of them had, none of them were making this up, because it had horrible repercussions in their lives. And what the point of the study was, just to finish the story, the point of the study is what can we do to help them? And as it turned out, the study group who was asked not to bend for as long as possible in the morning, some of them could go up to an hour, and they gave them, they gave them training. We had a physical therapist, gave them training in how to get out of bed, how to do everything that they do in the morning without bending, which I mean, that is nearly impossible to do, but the ones that were able to do it for the longest, actually, they had the best results. The ones who did physical therapy exercises didn't help. The ones who did, they had one that was they said it was a sham treatment. And it was some odd physical exercise. That didn't help. Nothing, that didn't help either. But the ones that helped the most was just not bending first thing in the morning for as long as possible. But that was the purpose of the exercise, of the study. What was interesting about it was the fact that these people were genuinely afflicted by something which was unidentifiable, and that's what's the oddest part of it. You know, there was no way to identify what caused it. So anyway, that's nonspecific idiopathic low back pain, and that afflicts a huge portion of low back pain sufferers. The other thing is how bad we are at remembering what causes low back pain. Okay? 19% could identify a cause within a 12-hour period of an event. Okay? Well, that sounds a little odd, but when you think about it, think of the last time you had a cold. Do you remember who you got it from or where? We speculate, we think, well, I had this happen, maybe that's where I got it. You can't remember that stuff. And low back pain is sort of like a cold. It comes on slowly. So it's very hard, unless you did something that really, really caused a great deal of pain. If it's a slowly atrophying type condition, you probably won't remember. So we're very bad at remembering. That's the 2 points from that slide. And the other point is this. Now, I don't think that's any secret. Largest workman's compensation comes from low back pain. That low back pain is a huge problem, and that's that. So the idiopathic part of it is a significant problem in low back pain sufferers.
Does it occur as we age also? Can we say, and if you're not active exercising?
Even if you are active, yes. When you get older, you do have an increase in lower back disorders just because of the biomechanical strain on your lower back. L4, L5, I'm finding out, is the point in your back that experiences the greatest cumulative biomechanical strain over the course of your life. Questions? All right, next week, before everybody runs off, next week, have you all collected your data over in the lab? Okay. Next week, we're going to start talking about biomechanics. After about an hour of lecturing, I'll stop and we'll talk about your assignment. And I'll also give you a way to, I probably should have did this before, but you think of a way to test your data to make sure that it's good data. And I don't think there will be a big, if anybody has a problem with their data, I don't think there will be a big problem with recollecting it. Mason, so Mason and Mark can help you, and it shouldn't be a problem. Should there be any problem, I don't think there will be. So next week, you should be able to start working on it, then you'll have 2 weeks to complete it, because it'll be due 2 weeks after that. Okay? All right, thanks.